we've all seen these numbers already. Hepatitis B and C related mortality increasing over time, with estimates being higher than those for HIV or other important infectious diseases. And most of that mortality is due to hepatitis B in the first place, and then hepatitis C. Hepatitis B, chronic hepatitis B by itself, leads to about 1 million cases of deaths each year. And most of that is due to liver cirrhosis and liver cancer. Now, the burden of hepatitis B-related mortality and hepatitis C-related mortality, as well as the fact that we have the tools to actually prevent this mortality, led the WHO to call for the elimination of viral hepatitis by 2030, which means a reduction of 90% in incidence and 65% in mortality. Now, to me, these goals can be achieved if we address 3 or 4 aspects which are really important. And the first one is prevention, the second one is testing, treatment, and I added information and knowledge because I think it's a big part, especially for sub-Saharan Africa. And that color code of green, blue, yellow, and red will accompany us now for the next few slides. And I'll try to give you a glimpse of what is important in these different 4 topics for us to be able to reach hepatitis B and C elimination. And obviously, I'll speak more about hepatitis B than C, because in sub-Saharan Africa, hepatitis B is more important in terms of morbidity and mortality. One very important aspect to understand when we look at hepatitis B in Africa is the fact that transmission is very much different than what we see here. The left part of the graph shows you the situation in Europe. So typically, adults are being infected with hepatitis B, usually through horizontal ways, so sexual transmission in injection drug users. And when someone is infected as an adult, the chance of developing chronic active hepatitis B infection is quite low, so 5 to 10% generally of people. Completely different situation in Africa and Asia, where most people who are infected are actually children, small children, who are infected either vertically, so from mother to child, or in early childhood. Call it household transmission. And when a baby or a child is infected with hepatitis B, then the chance of that baby or child developing chronic active hepatitis B is very high. More than 50% of these children will develop chronic hepatitis B. And so what can we do in terms of prevention? Obviously, the most important aspect is hepatitis B vaccination. And I'm just briefly showing you why we are convinced that hepatitis B vaccination is so important. That's a success story in Taiwan, which is really probably the first country to show that type of strong results. In Taiwan, in the 80s, over 10% of children below the age of 6 were infected with hepatitis B. They started to launch a campaign, a national campaign to vaccinate all neonates in 84. In 87, they extended it to all children. In 90, they extended it to all adults. And within 10 years, you had a reduction of hepatitis B, chronic hepatitis B prevalence from over 10% to less than 1% in those children. So a massive impact on hepatitis B prevalence, which translated into massive impact in terms of health benefits. On the right, you can see the mortality related to liver diseases among, about male who were born before vaccination, very high. And if you look at the other curves in male after the start of the vaccination campaign, where you see that mortality related to liver disease was much, much lower. So a huge impact on morbidity and mortality. Based on this, you all know that it was really advised to each country to implement hepatitis B vaccination. So the 3 doses starting at 6 weeks of age. And uptake was actually really good all over the place, even in sub-Saharan Africa, which is the dark green color here, where prevalence or coverage of hepatitis B 3-dose vaccination was over 75% in 2020. So that was actually very nice, and it translated into health benefits in Africa as well. This is a nice study from Malawi showing hepatitis B prevalence in the different age groups on a national survey. And when you look at the right side of the graph, you see hepatitis B prevalence in people born after the implementation of hepatitis B vaccine, often prevalence 4, 5, 6%. On the left side of the graph, you see prevalence in children born after the implementation of vaccination, and you see that prevalence is way below 1% in those children. So in that country, the vaccine impact was over 95%, and it's been similar in many other countries. But this is one of the countries where you have good data on it. Now, the problem is when you have a continent like Africa, where the prevalence of hepatitis B infection in children below 5 is very high, still 2, 3, 4%, that means that giving a vaccination schedule after 6 weeks is not enough, right? Because we know that a lot of those transmission will occur through vertical transmission from mother to the child. And so some modeling studies showed that the proportion of transmission due to vertical transmission is increasing in Africa. That's the modeling study on the right. If you look at 1990, for example, you see the big green part. That's the proportion of people that are infected in early childhood. And if you vaccinate after 6 weeks, you really lead to a big drop in that green part. But the part at the bottom, the purple part, which is neonatal transmission, stays. And so if you look at the situation in 2020 or 30, the big chunk of new infections for hepatitis B will be among neonates. So you need to do something about it, and the right way to address this is the birth dose vaccination. And modeling studies have shown that if we don't implement the birth dose vaccination, we'll do like the red curve, and we won't achieve the elimination targets for neonatal transmission. Whereas if we implement the birth dose vaccination in every country for every child, we will reach much sooner those targets that we have for the elimination of vertical transmission. So very important to implement a birth dose vaccination everywhere. Now, we're not doing very good at this. And so that's the WHO estimates from 2017, from the report 2017. And if you focus on the African curve, which is the yellow one, according to WHO estimates, less than 10% of babies that are born from hepatitis B infected mothers are vaccinated with the birth dose vaccination. So very poor uptake. And if we refer to scientific literature, there's a meta-analysis that looked at this recently, and the prevalence is even lower. And this probably reflects better the situation in most of the African countries. There is less than 1% of children that are vaccinated at birth. So why is that so low? There's many reasons why this is so low. There's structural reasons. Just one aspect, in many countries, if you look at Niger or Burkina Faso, many children will be born at home. So outside of healthcare, of the healthcare system, it's very difficult to bring on that first day after birth, the birth dose vaccination. Other reasons are, and probably the most important one, is political will. So there's very few countries in Africa that are actually implementing a national strategy of birth dose vaccination to date. And there's a whole aspect around social cultural acceptability. There's many studies that show that if a population is not ready for that, then there will be many women who will not accept a vaccination on the first day of life of their children. So people need to be prepared and informed. One good news, there's one country that actually really achieved those targets. That's Cabo Verde. Of course, a smaller country, so it may have been a bit easier, but it needed political will as well. In 2019, 99% of children had received their birth dose vaccination. They actually only had 4 children that didn't receive their birth dose on the first day in 2018. So it's feasible. Let's talk about testing. And we've talked about testing already. My previous speakers did, so I'm not going to spend a lot of time on testing for hepatitis B, but just 2 situations. Africa, Europe. In Africa, and it was mentioned earlier, all of the guidelines say if a prevalence in a specific population is over 2%, we need to test everyone. So that's the situation for the whole of sub-Saharan Africa. You always have a prevalence over 2%, so everyone needs to be tested. And that's a huge challenge to be able to implement strategies to test for the whole population. The situation is different in Europe. We talked about it. When the prevalence, the overall general prevalence is lower, you need to test for people who are most affected by it. And we've talked about migrants, and the graph on the bottom right shows you trends from Swiss Federal Office of Public Health numbers, showing you trends of new incidence of hepatitis B, new cases of hepatitis B, which sort of remain stable throughout the country until 2015, but clearly increase among migrants. So a strategy of testing migrants from highly affected areas is certainly very reasonable. This is really, besides the birth dose vaccination, hepatitis B testing uptake is really what hurts in Africa because we're doing very, very bad at it. If you look at the cascade of care, that's the global cascade of care for hepatitis B management, the first gap is absolutely massive. You see that overall in the world, only about 10% of people have been tested for hepatitis B, but you don't even see the color for the African continent here in that second bar because it's nowhere. It's 0.3% of people who are affected by hepatitis B who have been tested. On the side, numbers are not very much higher for European or other regions for that aspect of the cascade of care either. But certainly that's one of the big aspects where implementation and uptake of testing needs to be improved. This is the part where I'll just talk a little bit about Hep C because we really don't know much about Hep C epidemiology in Africa. And as you know, there's several strategies for testing for hepatitis C. We've talked about focused testing in specific high-risk groups, and this applies for almost all regions and all countries in Africa. But there's also two other strategies. There's the general population testing, which is a strategy that some countries apply, difficult to apply, but certainly in Egypt, that's one of the countries that started to apply general testing because of their well-known epidemic. And then there's this other strategy geared to Philippe and other people in the room, the birth cohort testing strategy. And I'll show you an example of Cameroon to see that it doesn't only occur in Europe or America, but there's also countries in Africa where this strategy should be feasible. I was going to tell you we really don't know much about hepatitis C epidemiology in Africa, and I'm just showing you a few papers which shows you the patchwork of data that we have. A study in Morocco showed that barbers were more affected than others. There's a study in Tunisia showing that hemophiliacs are much more affected than others. Then there's a general population situation in Egypt, and on the top right, there's the very let's say, emerging situation of injection drug use in big cities in Africa. And that's one of the studies that clearly showed that in Dakar, Senegal, over 20% of people who inject drugs are actually infected with hepatitis C. So even in Africa, there's a strong interest in testing people who inject drugs or people who use drugs overall. So the birth cohort, this is a very nice study, one of the only ones that actually looked at that aspect in African countries. In Cameroon, study published in 2005, which looked at prevalence of hepatitis C in several regions in Cameroon according to age. And on the graph, you see that if you go to the left of the graph, people that were born in 1940 or 50s in some region of Cameroon are very much more affected by hepatitis C. In some villages, over 50–60% prevalence of hepatitis C among older people. So this is probably in relationship to some form of healthcare intervention, be it vaccination or treatment. But that happens in several countries, and we know that from Central Africa, which is more affected than other places in Africa with hepatitis C, this is certainly something that would make sense to test older populations in some of the countries. 1.5 minutes on treatment, and I won't talk about hepatitis C treatment because you all know the difficulties in access to hepatitis C treatment for African countries. But I think the situation about hepatitis B treatment is even more important to raise because treatment with tenofovir is supposed to be available everywhere. There's generic tenofovir now available in almost all countries for actually not too much money. So it costs between $5 and $10 per month, which is still too much for many people. But that's the current price in many countries. So it should be available for patients. Now, why are people not treated? So I taught you about testing, so most people are not tested. But look at this algorithm that the WHO recommends for eligibility assessment for treatment of hepatitis B. Extremely complicated, not only because it looks complicated, but also because it relies on testing that is often not available, right? You need to be assessing liver cirrhosis, ideally with FibroScan, which is often not available. You need to be doing hepatitis B viral load to know about the current replication of hepatitis B, which is also often not available. So a mix of testing that you don't have and also guidelines and recommendations which are quite restrictive. And I just want to show you one example of our hepatitis B cohort in Senegal. This was more than 1,000 people with chronic hepatitis B, but asymptomatic. So people who did not come to the clinic because they had signs of liver disease. Those are asymptomatic people, 1,000 people. And if you look at how they're distributed according to the different groups, these are, oh, that's weird. Can you see? Wow, okay, I won't do that. It's gonna... So on the left side, you have the 3 criteria that we use to start treatment. Liver fibrosis, cirrhosis, in the middle, hepatitis B viral load, and then transaminases. The yellow is good, meaning no sign of active disease. And you can see that most of our patients that we see that are asymptomatic don't have liver cirrhosis. About 5–6% have liver cirrhosis. A lot of them, most don't have elevated transaminases, but there's quite a lot of people who have hepatitis B replication. So 70% have over 2,000 units. If you look at treatment eligibility based on those 3 criteria, about 10–15% are eligible for antiviral therapy. So we treat about 10–15%, but that is according to criteria derived from European and Asian studies. And we have absolutely no clue if these are the patients that really need to be treated in Africa, considering that many are exposed to aflatoxin and to other risk factors for liver cancer. So that's who we treat, but probably this is much too restrictive, right? And an example on the right is just an illustration of how it is. This is one of our patients that had transaminases in the yellow, hepatitis B viral load below 2,000 all of the time, that had no cirrhosis, no fibrosis, no other risk factors, and he came to us with liver cancer after having missed 1 appointment. So clearly, we're not doing well enough because that person wasn't treated and should have been treated, right? But we didn't know. So there needs to be more research on this for us to know who needs to be treated and who doesn't need to be treated. And I'll end with the information part. You realize in many countries that not only healthcare workers, but also the population is very badly informed about hepatitis B and C. This is a study we did with our colleagues, social anthropologists in Senegal. We did a press review, so not a literature, scientific literature review, but a press review from online newspapers and all that. We looked at what was published on hepatitis B for the past, I think it was 10 years. You see on the right, if you look on the far right, this is the month when newspapers publish articles on hepatitis B. And it's all around July, which is World Hepatitis Day. So it's good news that they used World Hepatitis Day to publish things on hepatitis. But on the left side, you see the years, and you see that until 2019, there were regularly some papers, and then COVID came, 2020, and no one cares about hepatitis B and C anymore, right? And when you look at what is published, it's usually stuff that scares people, or it's treatment and other sorts of hepatitis B and C management that really doesn't really work much, and it's mostly people who try to make money off people trying to sell things that don't really work. So misinformation and bad information is key and is really the standard in most of those newspapers. Healthcare workers are very badly informed as well. This is a study we did in 120 general practitioners and specialists in 3 cities in Senegal. And you can see this is just one glimpse of the study looking at knowledge on hepatitis. And if you look at the second line, we asked those healthcare workers, can hepatitis B vaccine be safely administered to newborn? And half of them said no. And if you asked them, can it lead to infertility? Half of them said yes. And these are generalists and specialists in teaching hospitals in Senegal. And I can tell you it's exactly the same thing everywhere, because hepatitis B and C is not included in the curriculum of medical doctors in a significant way. So there's a lot of work to do in information and knowledge in healthcare practitioners, but also in the general population. During the Francophone HIV conference in April in Marseille, before that I had to hold a talk on a similar topic, and I asked a network of healthcare workers we have in West Africa. So that was 200 healthcare workers that responded to my question: what are the biggest challenges in hepatitis B care in your country? And I was very surprised to see that 70% said it's the lack of knowledge on hepatitis B from the general public. I wasn't expecting that as a response. And the reason number 4 was the lack of knowledge in healthcare workers. And that's doctors responding to me. Right? So it's absolutely clear that this is one of the big gaps that we have. And then obviously reasons 2 and 3 are really difficulties in access to tools and lab stuff and diagnostic procedures. I'll end with this. WHO has actually launched a regional strategy for elimination of hepatitis B and C, and they set targets to be achieved by 2020. And this is, I think, quite nice because they were tailored to the African context. And the biggest, or the most important one, the most prominent one, was that all 47 countries should develop a national action plan for prevention and care of viral hepatitis B and C. And then there's other objectives that they set. And what I really like about it is this: they came up with the hepatitis scorecard, which allows you to really track what is being done in these different countries. And so it looks like that on the left side, one line per country. And when we zoom in for how it looks like, you see the blue part is numbers on prevalence and incidence of Hep B and Hep C. And on the right part, you see the indicators. And the first of those indicators is the National Strategic Plan for Viral Hepatitis. And if you look at the big card, you see that about half of all countries in Africa don't have one of those strategies. And if we look at the nicest one, which is number 3, that's the 3-dose vaccination for hepatitis B, you see that almost all of the countries are in green or yellow. And then we have our 2 very bad ones, or even 3 very bad ones, testing, treatment, where everything is red. But at least this really shows you where we are and allows you to track what needs to be done. And I think that's a very nice way to move forward. Let me finish by a few take-home messages. I showed you that 1% of the population has chronic hepatitis C in Africa, and here focus on key population, whereas in the general population, it's 5 to 10% of hepatitis B infection. Priority for prevention, hepatitis B vaccination, and the birth dose for hepatitis B. I need to say here that the birth dose doesn't solve every problem. We know it. There also needs some treatment for some pregnant mothers, but I think that's really the key aspect here. Priorities for testing, we need to find strategies to implement testing for Hep B in the general population, and we need to get to know more about the epidemiology of Hep C in specific risk populations. Priorities for treatment, there needs to be cheaper hepatitis C treatment, that's obvious, but also simpler and probably more inclusive hepatitis B treatment guidelines. Information, 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 and we need to improve every step of the cascade. That's absolutely key. And we need to have more research to inform policy. I think that's also one thing I haven't illustrated too much, but there's very, very little research on hepatitis B in Europe, for instance, but there's even much less in Africa. And we have good reasons to think that hepatitis B natural history, response to treatment is very much different in the African setting, given that they live with their hepatitis B infection for their whole life compared to our patients. And I'll end with that. Thank you very much.